Hi, everybody. It is 12 noon, so we'll go ahead and get started. Welcome to the Southwest affiliate of the American Heart Association's webinar focused on resuscitation science updates. For a full list of upcoming webinars, visit www.heart.org/SWA quality. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. All slides, handouts, and participation certificates will be sent to attendees within a week of the call. Please also visit www.heart.org/SWA quality to view the recording of today's webinar. I am pleased to announce that Deborah Hale, Tanya Truitt, Luis Valle, Amber Battles, and Cherie Boxberger will be leading today's webinar. Our first presenter, Deborah Hale, has worked with the American Heart Association for more than 20 years as a volunteer. Deborah began a career in emergency medical services as an EMTB, during which time she attended school to become a licensed practical nurse and later school for registered nurse. She is currently working as Senior National Training Consultant in the Education and Implementation Department of Product Development and Education. Our second presenter, Tanya Truitt, is a Senior Manager, QSI Programs and Operations Resuscitation and Heart Failure with American Heart Association's Get With The Guideline. Tanya has over 20 years experience as a critical care nurse and specializes in resuscitation. She was one of the founding members of NRCPR, now Get With The Guidelines Resuscitation. Our third presenter, Luis Valle, has worked in several areas including telemetry, emergency department, cardiovascular, medical, surgical, neuro ICU, and bone marrow transplant. Luis currently works at Medical City Dallas and Medical City Children's Hospital as an administrative supervisor. Our fourth presenter, Amber Battles, has worked for the American Heart Association for 6 years in emergency cardiovascular care. Amber's current focus is improving patient outcomes through the implementation of the RQI program in hospitals across North Texas. Our fifth and final presenter, Cherie Boxberger, has a master's in exercise physiology, an MBA, and is a certified professional in healthcare quality. Her work in unfunded statewide projects brings hospitals of all sizes together to pursue improved survival with an emphasis on the needs of the critical access in small community hospitals. On today's agenda, we will be focusing on 2017 AHA Focused Update, Get With The Guidelines, Resus Difficult Measures, Resus Quality and Improvement, better known as RQI, Changing the Culture of CPR Competency, and last but not least, upcoming educational opportunities. Now we will begin our presentation, and I will turn the webinar over to Deborah.
Thank you very much. This is Deborah Hale, and if you can go to the next slide, should be the title slide for me. There you go. And that is my name and the department that I work in. That's fine. You can go ahead. Next slide. There you go. The slide that was previously there showed me working in an ECC. As mentioned, I work in a department called Education Implementation. We work very closely with all other departments, including product development and ECC science. And so basically in my job, I have a lot of collaboration with those departments in many different areas. So as mentioned, I am going to give some information about the focused update, but I think I need to kind of give you a little bit of history in case you're not all on the same page with why we are going toward the focused update. You need to understand what's happened in the past. Historically, we've been on a 5-year cycle in the ECC world, and it's been that way ever since I can't even recall when it started, to be very honest with you, as I go so far back. We work, AHA works with the IL Corps, and whatever research and or science that's built up over a 5-year period, that then becomes what we call our new guidelines. They've been released on the 5 years, so 2005, 2010, 2015. And there's a lot of work and effort that goes into those guidelines to make sure that we retain the rights to the science before we publish the science. And so it's a really big thing and a really big deal. As research and science indicates, we in ECC update all of our products, so the basic life support, the advanced cardiac life support, PALS, PAIRS, Heart Saver, all of the courses that we have, we update them with the new science on that 5-year mark every 5 years. The problem is that in ECC, with the limited resources, i.e. people, we don't have the ability and have never had the capabilities of updating everything all at once. So we have staggered releases of basic life support, advanced cardiac life support, and the product lines then just kind of stagger release after that, which also helps our training network because they can't spend all of the money all at once for all of the products either. But it does cause a delay in getting new product out that has current science. And when you consider that we are also international, then you're looking at translations for the instructor manuals, DVDs, provider manuals, all of the materials, all of the pieces and parts that the instructors need to teach the new science once it's updated. It becomes a really big challenge. So in the age of technology and rapid fire information sharing, our business needs us to update more frequently because oftentimes there's news releases of new science and new information. One, for instance, would be the information recently released about the blood pressure. And although our materials are not incorrect, they're not as correct or as updated as they need to be. And another thing that the focused update created within the training network is a big concern of whether or not we're going to update our materials more frequently because our training network is used to the 5-year cycle. So they've been accustomed to budgeting every 5 years. Now they don't really know how to budget, and so that may be a concern that you are hearing when you're talking to some of your customers. The first focused update did not really warrant a new reprint, so we kind of got off lucky on that one. Another thing that we can do to be proactive when you're talking with the customers is just reassure the network, point them to the information that's on the instructor network, which tells them that we're not going to update any materials with this last and our first release of focused updates. And also plugging ebooks. With ebooks, the information is automatically pushed to the ebook, and so right away the user will always have an updated copy regardless of what changes happen and when. Next slide, please. If you have not been able to see or gotten any of the information, what's on the slide is the first focused update that was released in November. It was rather light in content, and mostly if you're looking at it, you can see that it really reinforces what we've already stated in our Guidelines 2015 information, and it's also information that further supports our recognized need for bystander involvement. It's absolutely critical that we all work toward the mission of educating the public on CPR and how much that action could save more lives. We could effectively meet our goals in 2020 if we actually involve more bystander CPR and the willingness to act with events that unfold in front of them. Advocacy has helped a tremendous amount by raising awareness and education with CPR as the school's graduation requirement. We have almost all states now that are participating in the graduation requirement, and it's really amazing thing that's happening across the nation with that. We're finding out more save stories every single day. ECC and AHA has also worked on placing the CPR kiosks in large airports. I don't know if you saw the news, but last week we actually launched 3 more, which brings our current total to 20. There are a lot of save stories that are coming about from the CPR kiosk, people that are just hanging around. I was at ECCU last week, and we had a guy just was so elated, came up to the booth and told his safe story about how he had been in an airport and had seen somebody do CPR that had just worked on the kiosk. And so it's really doing a wonderful thing. So these focused updates that were released really just basically support what we've already stated and or slightly clarify some of the information from before. Next slide, please. So if you want more information, the website eccguidelines.heart.org is where you can go to get that. There's a lot of information on there that is public worthy, so you can certainly share that information, that website out. Not only will you find the latest guidelines and the latest focused updates, this website will be updated as needed when we do release more updates, but you can also find what we call the highlights, which really is an easy way to read all of the guidelines and all of the information that we launched in 15. If there are any questions, please don't hesitate to contact me. You've got my name and email address that was on the other slide, and I understand you're going to get copies of these slides. And also, please do visit the ECCGuidelines.HART.org website and familiarize yourself so that you're able to point to resources as your customers ask you questions. That would be the end of my presentation. Are we taking questions now or later?
We will take questions at the end of the presentation.
Gotcha. Thank you.
Okay, this is Tanya Truitt, and I will take over the next part if you want to progress to the next slide. So what I want to do is talk a little bit about Get With the Guidelines Resuscitation. Just keep in mind that it is the largest event code database in the world. We have over 902,000 patients entered into it of all ages, from newly born all the way through adults. We have over 408 CPA events, cardiopulmonary arrest events, and over 624,000 MET events, which is medical emergency team events. It is a data set that was developed with in-depth coding instructions, our operational definitions by field of resuscitation experts that are not only national but international. We have over 108 research studies that have already been published out of Get With the Guidelines Resuscitation, 13 of which have just been published this year. And we'll actually be sending out a list of those for anybody who's interested in looking at those. But we talk about the research, but in reality, that is not what this database is about. What this database is about is quality improvement. The intention behind the database has always been, from the very beginning, how do we improve the quality of resuscitation within hospitals and therefore improve patient outcomes. So next slide, please. I'm just going to talk about adults, because if I try to talk about all the patient populations, we'd be here all day. So I'm just going to talk about adults. And for adults, there are 5 key metrics that we look at. And those 5 key metrics are survival to hospital discharge, decrease in the time to defibrillation, decrease unmonitored, unwitnessed arrest, time to first epi, and then confirmation of endotracheal tube placement. Next, please. What I'm going to focus mostly on is these two metrics, decrease in the time to defibrillation and confirmation of endotracheal tube placement. But before I get into that, let me talk just a second about survival to discharge. Survival to discharge, we look at it in a hospital as a very important index, but if we don't look at risk-adjusted survival to discharge, it's hard to compare what we're doing at any individual hospital with any other hospital. So every year, Get With the Guidelines Resuscitation puts out a risk-adjusted survival to discharge report. So if you have not found that report and you're a member of Get With the Guidelines Resuscitation, then make sure that you look for it on the community page. If you, in the 2017, I'm going back a few years here, the 2017 risk-adjusted survival reports will be put out somewhere in the end of April, 1st of May. But it's very important that you actually get your data put in by the end of January to be included in that risk-adjusted survival report. It will be updated, but just kind of that out there. So let's focus on the measures that people have the most trouble with, decreasing the time to defibrillation and confirmation of endotracheal tube placement. And let's talk a little bit about why these are important and why people are struggling with them, because we do acknowledge people are struggling with them. Next slide. So here is what we see when we look across the board at Southwest Affiliate, and it's not much different than any other affiliate, by the way. Next slide, please. The two that we really want to focus on is the time to shock, the first one, and if you see that the blue line at the top is the 85% requirement, and you can see that by the graph that we are well below that, and we are across the nation in time to defibrillation in less than 2 minutes. And then the other one is airway confirmation, which is a little bit of a change of a measure from last year. So we're going to talk a little bit more about that as well, and some of the things that you can do to look at that. So next slide. Let's start with time to defibrillation. And I am not going to bore you by reading this to you, but what I want you to realize, and one of the biggest questions that I get almost across the board, is why is it equal to in less than 2 minutes? So let's start there. The primary reason for that is that we do not record codes in seconds. When we get to that point, and someday I hope that in my lifetime we will get to that point, and I think we will, that we actually have the ability to track it within seconds, then we'll start looking at something different, at this measure a little bit different. But for now, when we say 2 minutes, it's really 2 minutes equal to or less than 2 minutes and 59 seconds. So we're really saying less than 3 minutes. So, you know, it's all in the wording of it. It was adopted years ago. Time to defibrillation has been stressed since 1985, I know, and probably a little bit before then. So it has been stressed all along. Next slide. It is the definitive treatment, and we know that, and this is the big key, is that we know that if we can defibrillate these patients early enough, they have a significantly increased chance of survival. Next slide. This is out of one of the studies, and I think this kind of really brings it home. So you can see the p-values are great, but look at if you can get a patient shocked in less than or equal to 1 minute, that's even knowing we have issues with time when we start talking about cardiac arrest events. But if you can get them shocked within that first equal to or less than that first minute, then their chances of survival are 40%. Some studies have even shown higher than that. If it's in 2 minutes, within that 2 minutes and 59 seconds, then it's almost as high. So that's the reason why we have become so focused on this less than 3 minutes. You can see the significant drop at 3 minutes, and then it just goes down from there. We want to get these patients early on in their VFib or pulseless VTAC, convert them before they degenerate into asystole, something that is much, much harder to get survival from. Next slide. So the second one that we're going to talk about is confirmation of airway placement. This, too, has been a big change for us in this last year. In I believe it was 20, maybe it was 2000. I think it was 2000, maybe 2005. I should have looked that up and didn't. But in one of those years, we started saying that auscultation, bilateral breath sounds, was not enough when we look at confirmation of endotracheal tube placement. We need to have some mechanical device that the human error associated with that was just not is too high. So at that point, we put in the measure to look at using some device to confirm placement. When this year's 2015 guidelines came out, it became apparent by looking at all the research studies that have been published that it's more important, or as important, I should say, in a cardiac arrest event that we monitor, either continuously monitor placement of endotracheal tubes because they get pulled out and dislodged during events, or at least confirm that it is in the right place at some point during the event. Next slide. So what we did is we updated the Get With the Guidelines program to actually look at this measure, to actually look at whether or not the placement was verified by a mechanical device during the event. Now, reality is we believed, and I think that most of you will probably agree with us, that this is done during events. The problem is often for us is it's not documented. So we have spent the last year trying to encourage sites to look at it, to find ways to get it documented, whether it's being done by a respiratory therapist that attends or an anesthesiologist, whoever comes to the code event, to get it documented so that it can be recorded. For recognition purposes, this year we'll actually we'll be able to look at the old measure or the new measure for recognition. But Next year, that changes. So in 2018, it becomes very, very important that if we haven't managed to fix this in our institutions to where documentation of this intervention that is occurring in most of our institutions is now being documented prior to 2018. So this is the time to learn more about it and think more about how do you improve the documentation and make sure that this is occurring, whether it's by continuous method or whether it's a one-time confirmation or multiple-time confirmation, some method of confirming placement of endotracheal tube during the event itself, not just after the tube was placed. Next slide. We've spelled out the rationale, and if you would like a copy of this rationale, we've got it spelled out very clearly with all the research behind it, and you can certainly contact your QI director to get a copy of this, or Larissa, or whoever is the lead on this email chain, and we can certainly get you a copy of that document to actually spell out not just in the general terms here, but actually give you the studies that you can use in your institution to support this change in our rationale and process. Next slide. Now I will turn it over to Louise.
Hey there, can everybody hear me?
Yes, we can.
All right, perfect. So my name is Luis. I'm one of the nurses here at Medical City. I'm an administrative supervisor, and fortunately, I happen to work with a fantastic group of individuals that have really helped me along the way with this process. So like you spoke, there are quite a few challenges to meeting our measures. So the first one, next slide, please. The first one I want to talk about is confirmation of the airway. And you are absolutely correct when you say that people do actually verify the airway. It's just always documentation. So what I really want to talk about is teamwork, because what happens is the very first person that's going to be there at the bedside next to the physician will be the respiratory therapist. So really this should be the respiratory therapist that always owns the skill. In our hospital, we always have a respiratory therapist right there ready with the capnography ready to go. So we always verify it, but there's always a lot of things happening. So you want to make sure that there's a second person that double checks this. So really depending on what your hospital has as a code team should really depend on how you structure this. But for us, we have a rapid response team, of course, that follows up. And in our codes, the rapid response nurse is the team leader. So if the respiratory therapist for some odd reason didn't verify this tube, there's the rapid response nurse that points out, hey, let's make sure that we do double check this. Let's go ahead and do it now. Just in case this does get missed at that point, then the second person catches it on. And also you can always have any other team. So for our pediatric hospital, which does fantastic, they have the neonatal transport team that responds. They also have the PICU charge nurse. So they're all trained in being the second person to verify any process along the way the code blue. So this helps, as well as streamlining a process. So to me, I like to keep it very simple. We always have all these courses that teach us to do a lot of things. We have a lot of checks. Let's do this, let's do that, make sure that's done. But for me, I always teach, okay, intubate and verify. Intubate and verify, very simple. We make sure we implement this in our ACLS. Our education department, every time they teach ACLS, they always train, part of the checkoff is you intubate and you verify right away. And like you mentioned, it is documentation. Documentation gets missed all the time by staff. So the process that we have in place is once the code ends, we verify the code sheet as a team together. So let's say we run the code. I like to dictate to the person that I selected myself to write, and I tell them times, this is what you need to be doing, please do this, please do that, write this time down. So at the end, whenever we go back and we finish, I like to do a hot debrief with the staff, talk about what happened, what we did, how we worked well, and areas of improvement. But we also go through the code sheet because I want to make sure that that got documented correctly and that we also have the times correct. So this includes the physician, this includes the staff there, and this includes the team lead. So that helps ensure that you do get that documentation process right. I think I remember hearing a webinar as well where one hospital actually submitted the code sheets to the managers, and the manager had like 72 hours to review or so. And once they reviewed it, they submitted it into the code, whoever reviews them after that. So I highly encourage everybody to follow up on your code sheets and just make sure that you do debrief on them and make sure that we talk about it so that we can ensure that our documentation is done, because I guarantee about 75% of the time that's what happens. Somebody didn't check the box. So next slide. Okay, so time to shock. As you mentioned, this is a very, very important measure. We always want to make sure that we shock immediately, as fast as we can. We try to get there, try to get to the bedside, go ahead and see if we need a shock, and if we do, let's shock. Fortunately, I have a lot of new interns and new nurses that get hired on over here, and we like to put them with the rapid response team because we like to put them in the situation where they get to see firsthand what we do. And I really talk to staff about empowering. I teach a lot of courses to the new interns and to all our staff, and it's empower your staff. The biggest thing that I have seen is the bystander effect. So the bystander effect is when there's the presence of several people, so it discourages individuals from intervening in an emergency situation. Basically, there's a perceived diffusion of responsibility when there are more people at the bedside. Everybody's waiting for one person to start this. So I encourage staff, hey, if you don't feel a pulse, start CPR. I promise you, if that patient actually has a pulse, they will tell you to stop. So you want to continue to encourage your staff to take action. Let them know it's okay if, we would much rather you act than not act at all and just wait for something to happen. So I like to teach staff simple process again. You go ahead and start compressions, slap those pads on immediately. Those are the two things. Let's keep it simple. Start compressions, slap some pads on. Let's go from there. So I also encourage them to use an AED if they don't feel comfortable with a defibrillator. Even experienced nurses at the bedside, I've seen this patient will go into VFib or VTAC, and everybody just freezes. We know these code blues are really chaotic. Tension is really high, so everybody panics. Don't be afraid to tell your staff to use AED, even if it is a critical care nurse or they're newer or something like that. You want to make sure that you let your staff know, hey, if you don't know your rhythm, slap that AED mode on and let the AED take care of that. Like I said, even an experienced nurse will freeze in that situation, so it's perfectly fine to let your staff know it's okay to do that. You also, of course, want to make sure that your defibrillators are up to date with American Heart Association standards when you do encourage that. And back to touching on the streamlined process, make it simple. So I remember when I first got here to the hospital, we had a very lengthy education on codes, and it included like 21 steps, I think, when I first saw it. And I started working with our education department. They're fantastic, and we cut it down significantly. I'm like, let's just teach the important things. Let's teach someone how to save life and not just how to check boxes and make sure they did it. So we really started focusing on the areas that we needed to improve. So check a pulse, start compressions, slap some pads on, leave it on AED mode if you're not comfortable, and from there, you go ahead and you've started this process. By that time, our code team has responded, and we can continue to go to the more advanced measures, but really it's just teaching something simple and ensuring that the staff is comfortable and encouraged to go ahead and act and not step back from a situation like this. So that's what I have on mine. And I guess I'll have questions at the end.
Hi, Amber. Remember to come off mute, press *6.
Yes, I've just been talking away. Good afternoon, everybody. I'm Amber Battles, and I'm going to talk to you today about RQI. And truly, it is a disruptive form of resuscitation training in the hospital. It's been around for about 4 years. Our first adoption site was back in 2014. We've seen a lot of great successes for it, so I'm very excited to share more information with you about that program. Next slide, please. So the mission of AHA, for those of you who may not know, but it truly is to build healthier lives free of cardiovascular disease and stroke. And AHA has a vision of one day living in a world where no one dies of cardiac arrest. And we know we're far away from that, so we are looking at ways to make the biggest impact towards that vision. And back in 2010, ECC, Emergency Cardiovascular Care, Department of the AHA, came up with an impact goal to double patient survival in hospital by the year 2020. And today we're just focusing on the adult. So back then in 2010, the patient survival outcomes was roughly 19%. So the goal by 2020 is 38%. And at the end of 2017 right now, we're looking just under 25% at outcomes. So certainly we have moved the needle, but there is a long way to go to hit that goal. Next slide, please. So right now, our current state of resuscitation, we know that there is a major variance in survivals. In fact, over 40% difference in patient survival outcomes from hospitals of similar sizes and similar patient case mixes across the U.S. And while we know that not every patient can be saved, those who can be should be. And so the hospital that you're in when and if you do have a cardiac arrest should not determine what those rates are. We know that high quality CPR is the strongest predictor of survival, but it's not easy to hit that proper depth. And we also know that the psychomotor skills can decay in as little as 3 to 6 months following a training update. Next slide, please. So one of the focuses and highlights from our 2015 guidelines was the emphasis on immediate high-quality CPR before the code team arrives. Been in several hospitals where I've met with a Code Blue committee that said, you know, we don't understand why we arrive on the scene 4 minutes after somebody arrests and the nurse at the patient bedside has not begun immediate compressions. And the answer usually is because maybe that staff person has not performed CPR, or it's been 18 months since they've had a resuscitation training. Next slide, please. And also with our ECC guideline highlights from 2015, we saw the defined metrics of high quality CPR as a chest compression rate of 100 to no more than 120 compressions per minute, a depth of 2 to no more than 2.4 inches. And I'm going to stop there and just reinforce why the AHA is making feedback devices required in 2019, truly because we need an objective feedback device to be able to gauge that proper depth for muscle memory. It's very hard for the human eye to look at someone performing compressions and say, oh, that looks like you're only at about 1.8 or 2.2. This feedback needs to be precise. We also focused on more frequent assessment of skills training and self-instruction. Next slide, please. And again, we've recognized since really 2010 guidelines that there must be a change, that these once every 2-year training cycles are just not optimal. And in 2013, the AHA took it a step further to say, through our consensus statement, that poor quality CPR should be considered a preventable harm. Next slide, please. So what the RQI program is based on truly is a disruptive innovation. We want to shift the focus from I got to have a card to do my to work tomorrow into do I have the skills to actually save a life. So again, from that compliance, I'm doing this just because I have to do it, into an actual engagement, an active learning, and ownership of competencies. And again, from a mandate to a skills mastery. Next slide, please. So in 2015, we also learned that there's substantial evidence to suggest that mastery learning is the key to skills retention, and that it will directly prevent that skills decay. And you think about it, nobody wants to be on an airplane where a pilot only practices emergency landing once every 2 years. You want that repetitive practice, and not just so that they practice so often or so hard that they get it right, but actually practicing until they cannot get it wrong. That is the goal for resuscitation training. Next slide, please. So what does the platform look like exactly? Well, as you can tell, there is an RQI station. It is on wheels that they will live on the patient floors. in the hospitals so that it's easy access for employees. Essentially, the classroom comes to them. And once a quarter, keeping in mind that we are requiring once a quarter to directly address the skills decay, they will log in to the laptop scene attached to the RQI station, and they will go in and get what is called a learning event for that quarter. And that will require a set of psychomotor skills being compressions and ventilations. So quarter one, for example, you might have adult compressions and adult ventilations. And in the next quarter, it may be an infant activity. So we are currently offering BLS, ACLS, and PALS RQI for all 3 disciplines. You also, in addition to the psychomotor skills, will have online learning modules where you'll see interactive patient cases, but it's broken down into a very low dose, high frequency is the model, just to improve the skills retention and keep them fresh. Next slide, please. So after each student experience on an RQI station, they will be able to access immediately afterwards a debrief. So they'll receive an audio and visual coaching while they're doing their skills, but then they'll also see, their overall score was 86%. What did they do right? If they wanted to get a better score, what would they need to do? And so these are actually specific metrics that show them, your times for hands on the chest was only, 85%, or, you were only within the proper compression rate for 88% of the time. If you wanted to improve your score next time, you need to focus on that. So really creating an awareness. Next slide, please. So with the RQI Learning Management Platform, this is very automated. They will get updates alerting them as to when each new skills session is available, and also an automatic e-card comes included with this program. So as soon as a student logs on and successfully completes their skills at a station, they will have access to an e-card. And as long as they continue to do these skills on a quarterly basis, that's a perpetual card that will never expire. So they will never have to attend a live renewal class again. Next slide, please. So as a nice benefit to improving quality inside the hospitals, we've also noticed that it can be quite a major cost savings as well. Texas Health Presbyterian Dallas, as shown here, they were our first adoption site 4 years ago, and after the first 2 years, not only did they see a cost savings of over $250,000 per year in their resuscitation training, but their patient survival rates went from 39% to 60%. And there were no other initiatives during that time that they could attribute to those numbers other than the RQI program. So knowing that we can make that kind of an impact truly is justification for endorsing the RQI program as the gold standard for resuscitation training inside the hospitals. We've seen other success stories too. They just haven't been published like Dallas has. Next slide, please. So here are some of our early adopters. These are just really to name a few major systems. But in addition to these, we've gotten a lot of smaller surgical hospitals. Some rural facilities have seen the value in this training because no longer are they paying to outsource their training. No more mobile sim stations coming, 3 hours out to meet with them, and being short-staffed and not being able to afford employees to leave a patient bedside to go take their resuscitation class. So this has been a real value for them as well. But I'll pause there and go to the next slide. So that is the end of this presentation, and Life is Why. I'm happy to answer any questions pertaining to the program after this webinar. Thank you.
Thanks so much, Amber. This is Cherie Boxberger. Before I kind of talk about some educational opportunities, I'm going to turn it back to Audrey, who's going to help us facilitate questions and answers. be thinking about what you want to ask each of these presenters, and you can give us some more instructions on that, Audrey.
Sure. So thank you, speakers. Now we will begin our question and answer portion of today's webinar. You can either type your question into the Q&A box on the right-hand side of your screen or come off mute by pressing *6. Okay, so our first question is, how does the hospital impact the adoption of TCPR by our local emergency dispatchers?
Deborah, can you talk a little more about telephone CPR maybe? Don't forget the *6 so you can come back to us. I guess she's not. Deborah, are you with us? Maybe we lost her.
Deborah Hale. I'm not sure
yeah, go ahead, Deborah.
There you go. I'm not sure who the question was directed at. If it could be repeated one more time, and I'll do my best to try to answer.
They asked about the hospital, of how hospitals could help to get the adoption of telephone CPR. Can you talk a little more about that? Or do we have tools, et cetera, for communities to move in that direction?
Okay, yes. So the best way the best advice that I can provide is to work with your local EMS department and see what resources are already available so that you're not reinventing any wheels, and also so that you're connecting with the ones that really you need to connect with. Oftentimes the dispatch units are run either out of an EMS unit or out of your local police, county police, state police, wherever you happen to be. So start first with your local EMS, and I would strongly encourage you to follow any and all advice that they provide, and then also connect with the police department and the fire department, and even possibly consider going as far up as your state department of EMS wherever you reside. But start first with your local and then work from there.
Perfect. Thanks, Deborah. Another question for you. What was the previous recommendation for infants and children?
I keep hearing mute on and mute off in my ear. This is Deb again, and I will need to probably get that information back to you because I don't have it right here in front of my head. And so in the interest of time, I'll start looking for it while we go on to the next question, and if I have it before the end of the call, I will give it.
Thanks, Deborah. For Louise, please give us an idea how your code debrief looks.
Okay, so ideally whenever I do have a situation, so I've seen several codes before. I know the guidelines. I've seen several of them. So initially, let's say we get to the bedside and something's not quite going in order. Maybe we didn't have suction ready. You know, they started compressions, they have everything ready, but we just missed some measures along the line. I like to be very encouraging for staff, so I always start out with a good. I always say, okay, team, well, let's talk about what we had. Initially, I like to let them know that we're just going to debrief, talk about it, and I like to let the staff air out their feelings first. I don't want to control the conversation. So what I want to do is I want to open up the room basically for anybody to discuss what they feel. Initially, I start talking, and then I will let them say, okay, well, I felt like this is an area we could improve, we could do that. So I go back and I'll say, okay, well, this went well. We started compressions. We were doing this. We were bagging. We got the pads on quickly. We were doing quality compressions. And then I touch bases back on what they felt that they needed improvement. Of course, you always want to talk about it. And this is an area of improvement. This was not something negative. We don't want to talk down to the staff or any of the sort. We want to encourage them to, this is an area, let's focus on it. You acknowledge that this is where we could, and any area that they may not bring that I feel like we could have done a little bit better, I'll bring it up. I'll say, okay, maybe we may need to study the medications that we had. Maybe we had a little issue finding the medication. So just by letting starting the conversation, letting them air out what they feel needed, and then talking about the good and reflecting on the areas that we can improve, then we create an area that everybody can air out the concerns, but it's also not in negative light.
And this is Tanya. Can I interject something here too?
Sure.
So also I just want to encourage you, if you are looking at developing a debriefing or looking at your debriefing program, to go on to the Get With The Guidelines Resuscitation website, look under the toolkits and tools available, and we have actually worked with many of our participating hospitals and experts to develop some resources to use for the development of a debriefing program, including evaluation forms, et cetera. So you might find that useful as well.
Thank you. Does anyone else have any other questions? Remember to press star 6 to come off mute.
This is Deborah again. While we're waiting on the next question to come through, I wanted to make sure that I was going to provide accurate information. So in the Guidelines 2015, I'm looking more specifically in the highlights document, which you can find on the website that I provided. There is a summary document of high-quality CPR, and it's the easiest, quickest, fastest resource to kind of look at all of the ages, adult, child, and infant. On that, and also within the highlights and guidelines themselves, the emphasis has still been on providing both compressions and ventilations for children and infants. And I'm guessing that the question was geared more toward the second bullet of my slide that said, and I'll read this one, although I never read slides, infants and children pre-pubescent should receive chest compressions with rescue breaths. If rescuer is unwilling or unable to give breath, all infants and children should, at a minimum, receive chest compressions. So essentially what the focused update was is just to get somebody to do something. If you cannot, for whatever reason, will not, for whatever reason, provide rescue breathing, at a minimum, then do chest compression. So kind of a nod for the hands-only movement with infants and children in mind, as we have made very clear with adults. I hope that that answers your question. If not, please let me know.
All right, it's Cherie again. Do we have any more questions? This is a good opportunity. I know some of you who are already Get With The Guidelines, who if you've been struggling on that airway confirmation or on any of the other measures to have access to Tanya and or Louise. And then, of course, a great opportunity to have our ECC partners here as well. So last call on questions, just star 6 and ask your question. All right. Meanwhile, why don't you go ahead and find my last slide there. I don't think it's up. Ms. Audrey?
Sure. My computer just randomly wanted to restart. Oh. Give me 1 second.
That's okay. So kind of in summary today, so thank you for all of you for joining us. But I think it's really exciting when you look at the American Heart Association and the way that our science drives what we're recommending on the emergency cardiovascular care side of the business or on the rest of the measures on in-hospital cardiac arrest survival. You can definitely see that the scientists are always working, and that now that we're coming up with these focused updates, we'll be able to be acting upon the latest science, not always waiting the full 5 years, which still will probably have major updates in that time frame, but we'll be able to take advantage of those more frequent updates. On Get With The Guidelines, if there are those of you who are not using Get With The Guidelines resuscitation, I know that you're keeping track of your code blue data somewhere and of your MET team work. Most people are doing it on some sort of a spreadsheet. I encourage you to consider Get With The Guidelines resuscitation. If you have Get With The Guidelines resuscitation, but you're thinking, I'm not really using this to my full advantage, please talk to your Director of Quality Improvement, or you can email us at swaquality@heart.org, and we'll get your specific director to give you a call and to talk about how do you use your Get With The Guidelines module more effectively. Also to point out where your risk-adjusted cardiac survival report is that's put out there annually. That is something that's a real gem and part of Get With the Guidelines Resuscitation. I want to thank Amber for introducing the concept of RQI, or resuscitation quality improvement. Really excited about this and the fact that we're going to be able to have many more providers of CPR feeling super confident and competent at their skills. I'm hoping that this will also increase the number of bystanders, because as we're training our clinical staff better, I think those folks will be wanting to do that CPR out on the street. So I think that's exciting. Real quick, one slide back there, Audrey. I just want to, this is a quality improvement tool to Get With the Guidelines Resuscitation, but I wanted just to be able to show you that we are able to get many publications out of it. Research is derived from this information. And so you can see that over the years we've continued to have excellent peer-reviewed research that comes out of Get With the Guidelines Resuscitation. Again, if you're a provider of that and you would like to be able to use the data for some work or some research that you're doing, again, speak with your director on that. Next slide. We really want to continue to provide additional education. And so in the cardiac survival and the resuscitation world, our next program is actually later this week, and it's a national webinar on the significance of CPC and PCPC CPAC scores in resuscitation. I know as we look at prognostication for these types of patients, this is going to be important information. We will send out the promotion for this to everyone who's participated today if you didn't already receive it, but it was sent out nationally. We'll also have a quality exchange, and this is for Get With the Guidelines customers and not, on January 31st. From 8 to 9 Central Time, we are going to be going, looking at data specifically related to Get With the Guidelines Resuscitation. And then a wonderful face-to-face continuing education opportunity in Denver on April 12th, where we will be holding a Strive to Revive conference. It's going to include everything from pre-hospital through the in-hospital challenges. It'll include RQI as well as some information on prognostication. Our medical champion there in Denver is Dr. Sarah Perman, who is leading our continuing education team and putting that event together along with Julie Blakey, the director for Denver. I want to give you, we have just a couple of minutes. I want to give you a chance if you have any questions on RQI, how we might bring that to your hospital. If you have any questions related to Get With the Guidelines Resuscitation, it's a good opportunity to find a really high-performing hospital like Medical City, Dallas, and be able to pick Luis's brain. Or if you have any more questions as it relates to guideline updates. *6, or just type it in there and they can read it to us. Or maybe not, because she may have just died again. All right. Well, I encourage you, this is an important area, as you, I'm sure, are aware because you're resuscitation professionals. The Institute of Medicine said that we can save 50,000 lives by improving these types of things related to cardiac arrest survival, including improved CPR quality, using programs like RQI, or using your heart code programs or other programs, but assessing those skills more often. They also emphasize the need for registry and for quality improvement, and that's where Get With the Guidelines Resuscitation fits in. So I am so thankful for all of you for helping us to start that process to save those 50,000 lives. If you have any questions on any topic, just pop us an email at SWA, just like Southwest Airlines, except it stands for Southwest Affiliate, SWAquality@heart.org, and we'll get it to the correct person. And if there are no more questions, I want to thank our speakers for participating with us today. And Audrey, did you have any closing comments related to things that will follow up, be sent out to them?
Sure. So all slides, handouts, and participation certificates will be sent to attendees within a week of the call. And please also visit www.heart.org/SWA Quality to view the recording of today's webinar. Thanks, everybody, and the speakers, and have a great day, everyone.